When I was a resident, my favorite thing was fracture conference. So our next two sessions, we're going to focus more on fractures of the shoulder and the elbow. Our next moderator comes from Penn. He just left the operating room. He's Dr. Samir Mehta, who is the Director of Orthopedic Trauma at Hospital for the University of Pennsylvania. Our panelists will be Dr. Dean Harder from Geisinger, Michael Bursick, rocking the bow tie from Lancaster, Brian Legan, also at Good Shepherd in Penn, one of our physical therapists extraordinaire, Carrie Schwartzbach, who's from the area, one of our traumatologists, and my Persian brother, Dr. Silas Gary, who comes to us from Annapolis, Maryland, who also trained under Dr. Lisa Gallitz. Our topic is proximal humerus fractures. If it's broke, why fix it? And in Samir's case, he never saw a fracture he didn't want to fix. So hopefully there'll be some non-op here.
All right, well, thank you. We've got a great panel. We're going to hope to make this interactive. Audience participation is key. For those of you who've taken care of proximal humerus fractures of any sort, the older I get, the less I fix. They are a bane of my existence. How often does Namdari take a deep breath? I like that. All right. If you fix proximal humerus fractures, despair.com has a great poster for your OR. Discouragement because there's nothing standing between you and your goal but a total lack of talent and complete failure of will. And it's never bad to ask for help. I was walking through the operating room and one of my partners was doing an acetabulum, and if you look really carefully, the resident there is, and my partner doesn't know I have this picture, by the way, the resident there in the back who's now graduated is holding up a sign. If you look really carefully, the best is you can see the desperation in Russ's eyes as he holds up that help sign, and so don't be afraid to ask for help. So we're going to do this like Choose Your Own Adventure. How many people in the room read Choose Your Own Adventure books growing up? A couple of geeks in the room like me. Okay, great. So Choose Your Own Adventure books, you would read a page and it would tell you if you want to go down the black hole, go to page 84. If you want to climb the ladder, go to page 92. Then you go to that page and you die or something like that, right? So there's some famous Choose Your Own Adventure titles out there. My favorite's the third one. I work at Penn, so that's kind of my everyday. So having said that, these are your case choices. We can either let the audience pick one or the panelists pick one.
Dun, 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 dun.
I think I need surgery. How does that sound?
All right, I think I need surgery. Can you click on that, please? All right, here you go. What do you want to know?
Do we get a history or not?
Okay, sure.
Make one up.
This is it doesn't matter. AO means always operate.
Yeah.
Yeah.
Maybe a little bit.
So this is a 64-year-old female, ground level fall, dominant arm. No other injuries, no real significant medical history, typical 64-year-old.
I'm going to guess we don't get an axillary review, right? Is that the rule we get?
Yeah, no, there's no axillary review to get. This is how she shows up in clinic. I do have this though. A couple of CT cuts. What do you want to do?
Want me to talk?
Yeah, sure. Yeah, anybody.
I'm going to have to disagree with her. I don't think she needs surgery. And this is one of the comments that you made before we started is the older you get, the less you operate on these people. And I get it, the same thing. The more I've seen myself operate on some of these patients that maybe didn't need it, the worse I see them do. I think this patient will do fine with non-operative management.
Is there anything on this x-ray that would suggest that she needs surgery?
Yeah, I'd worry about the relative position of the tuberosity of the head. If this is truly just a valgus impacted with the greater tuberosity sort of open posteriorly, those patients do well. You can do them through a deltoid split. You lift the head, you get it back into the proper position, you support it with a graft, close the door on the greater tuberosity, and those patients in my hands are some of the best patients, the best surgery outcomes that I get. Okay. And I'd need to know more about on a CT to see if this is just a true purely valgus impacted, because sometimes you get the older patient that has just, it's the head's in valgus, but everything else is destroyed underneath it.
I know that there's nothing out of the ordinary in the CT. There's no sort of valgusization. There's no retroversion. It is just what you see, which is essentially impacted.
I think if we could possibly have a randomized prospective study on operating on this and non-op would win every time.
In terms of PT, Brian, what would you expect or what would you want to see for this patient if they came into your office?
So everything I do is basically impairment-based. The first thing you want to do is I always try not to screw it up and make this a somewhat non-displaced graded tuberosity fracture, a displaced graded tuberosity fracture. So for the first 6 weeks or so, I'm going to stay below 90 degrees. Early in my career, when I worked with Jerry and Joe, we used to not restrict passive range of motion in forward elevation, and that proved unsuccessful in a few patients. So I decided to just stay below 90 degrees for the first 6 weeks. I would do passive elevation, some external rotation, maybe do like a chair stretch or a table slide to unweight the arm, but really just to keep them moving, but make sure that we get good solid healing before we move on.
Yep. What if I told you this patient wasn't 64 but 44? Right hand dominant, male, female, doesn't matter.
I think in a 44-year-old with the tuberosity displacement, I think the valgus impacted do well surgically. So I would probably lean towards operating in a 44-year-old, but agree in a 64-year-old, I would leave this one alone.
Well, being 3 years younger than that patient, I take umbrage.
We're just operating on it 5 minutes ago. What are you talking about?
I said I would do it, therefore.
Michael, a 44-year-old, you operating on it?
No,
44, I would operate on this, but I agree on a 64, I would not.
So what's the age cutoff? Where do you, I guess my question becomes, where do you, so those of us who always operate, right? Where do you draw the line? I mean, because every year I get older, that age requirement gets a little bit higher, right?
I think for me, 55 to 60, it's a little bit of a general assessment of their health.
I think there's some data out there that says over the age of 60, the complication rate goes up astronomically when you do ORF. So 60-ish.
60-ish.
So being the oldest one in my group, old is always defined as me.
So one of the things that, I just want to bring this up, one of the things that we've been using more and more in the trauma world is this concept of a frailty index. I haven't seen much of that published in the shoulder literature, at least not with proximal humeri. Maybe I'm wrong. If someone wants to correct me, they can. But at least with hips and some other orthopedic trauma fractures, we've been looking at frailty as the measurement of age, if you will. Not necessarily physiologic age or chronologic age, but frailty as being the predictor of whether they're going to have success or failure. And there's some very nice data showing that frail patients do worse with surgery, at least with hip fractures. And I don't know if the same would be true for proximal humeri, but maybe an interesting question to look at. Anybody going to operate on this in a 64-year-old? Right hand dominant, low energy injury? Russ?
I was wondering, these patients, if they don't do well with non-op treatment, you can go in arthroscopically and do a tuberoplasty and repair the cuff in those patients if there's impingement, because she has a type 3 femoral, so, or at least has ossification of the ligament. So it's not the end of the world if you don't fix this early, or if they come in late. There are other options that aren't like me. You don't have to do an osteotomy and things like that to get this patient better if they don't do well with surgery, with non-op treatment. Sorry, so I mean, I would definitely lean towards non-op because there are other options to treat it delayed if there's an issue.
So I think that's the dilemma, and I'd love to hear the panelists' comments on this, is, you know, with all the literature out there pushing non-op treatment of proximal humerus fractures, or encouraging it at least, you know, are there certain fractures, like this one, for instance, if you wait on it, like Russ said, maybe it's not so bad if it doesn't work out, you have some alternative options. Are there scenarios, and is this one of them, that, you know, non-operative treatment, if it goes bad, you've really hosed the patient?
I mean, we just heard that there are some,
Yeah.
we heard there's some options. I mean, I probably would have done it, if this was treated non-operatively, I probably would have gone the osteotomy route, but there certainly are options. But I think, again, to me, this is such a chip shot to fix and get everything where it belongs and start early rehab. It's a very stable fracture. You don't worry, it's not like your typical three-parter where you actually have a varus injury and you worry about stability of your construct. When you fix these, this is a very strong construct, and I think that's just the time when you can figure out what to do rather than worry about doing it later.
And if you're fixing it, deltoid split or deltopec?
This is the perfect case to learn how to do a deltoid split. You come in, you're right in front of the pathology, you open up the rest of the graded tuberosity, you lift the head up, put a graft under it, close it, put your plate on, you're done. It's the case to learn how to do a deltoid split.
Gary?
Samir, is this an acute injury?
This is a acute injury. I mean, it's like by the time she sees me, it's 2 weeks old. It's a second opinion.
So if it's under a week, I would do closed reduction percutaneous pinning in this. And the problem is when the head begins to heal in that position, you try to knock it up, you can knock it completely off. But if it's acute within a week, this is a 15-minute closed reduction percutaneous pinning, and as was stated, it's a pretty stable construct. That's what I would do if it were acute.
And Jerry, remembering what you taught, if you can't get it in 15 minutes, let's just say it's not coming, it's not moving, you're not getting it. Are you opening it then? No, just going to leave it then. You're going to stop. Okay.
You know, that brings up a very interesting thing. Several years ago, I would have probably done that as well. I was a big fan of percutaneous pinning, closed reduction, until one day, and I don't know if you guys know Jerry Cush. Jerry Cush, one of our foot and ankle guys, he was my resident at the time. This really pretty heavy lady. I think she was about this age, about 64, relatively poor bone. We had a perfect reduction. We're so pleased with ourselves. She comes in for a 6-week post-op visit. And the x-ray, and we can't find any of her pins. Pins were all over the place. We went to the OR. One of them was actually in her peritoneum. I mean, these things can go all over the place in these people. And boy, I hardly ever do them anymore. It has to be somebody who's young with really, really, really good bone stock. So I would be worried about percutaneous pinning in that lady.
That's her at 6 months. So, you know, beautiful. Yeah, great. Awesome, right? All right, can you click the home key? In the back, can we click the home key?
Is this the same patient?
Same patient? Yeah. All right, next case. Take a pick. Chip shot, no brainer? All right. Last one. Yeah. We'll get to that one. All right, this is a 32-year-old. I forget what happened. Also right-hand dominant.
No more views?
Can you play the video? All right, Cyrus, 32-year-old.
I'm treating that non-operatively and following it closely.
Okay, 32-year-old following. And so what does that mean? So they come to your clinic. This happened. Ooh, go back, please. Oh.
Reverse.
Who hit that?
I did miss that.
Okay, all right. Okay, there you go. 32-year-old, it happened like, 4 or 5 days ago. They went to an urgent care, they got thrown in a sling, and now they're in your office.
Yeah, so close follow-up for that is weekly for the first 3 weeks, and then I push them out to the 6-week mark.
Okay, and what's your protocol for them? In terms of like, what, sling for 3 weeks?
I go
PT?
sling for 6 weeks.
Okay.
For this,
With his name on it.
yeah. I would put them in one with slight external rotation, neutral, and I would start him in therapy at the 2-week mark. So probably I would see him a week after he's been 5 days, and then start him in therapy after I see him, assuming it looks okay.
Okay. And you're going to use repeat X-rays as your guide?
Yes.
When somebody looks at these X-rays, everybody getting a CT scan on this?
Yeah, I do, because you don't know how displaced that is. And I would want to see an axial view, because sometimes these things are way posteriorly, and it's very hard to judge rotation on a 2-dimensional film. So I'd want to see the axial views of the CT before I decided what to do. But I also agree with, if I were treating non-op, weekly X-rays, I usually start pendulums immediately and then not do PT till I think at 3 weeks they're ready for it.
I agree. I think you need to get a CT scan anytime you have these greater tuberosity fractures, because you'll miss how displaced it is on the X-ray. But I think personally I would fix this one.
You would fix this one?
I would fix this.
I want to see how displaced it is.
I think this is
It's
going to be
displaced.
significantly posteriorly displaced, and I would probably lean toward fixing this one in this young patient.
When you go in there, they're usually wrapped way around the back.
Brian, when you get the PT script for this patient, it says, greater tuberosity fracture. Detail, what kind of detail do you want when you see on the diagnosis greater tuberosity fracture?
I'm sorry, what was the question?
I was asking Brian what kind of detail he wants when he sees greater tuberosity fracture on the PT script.
I'd like to know if it's displaced or not, whether it's displaced, whether it's angulated, any of that type of thing. Several years ago, we had a patient who had an undiagnosed grade 2
agree.
porosity
It's a-
fracture, and it had retracted so far back that when they went back surgically, she had an insufficient cuff and basically presented like a massive cuff tear. So for me, I want to know, is it stable? Is it not stable? Things of that nature, so that I know how to not make it worse.
Okay. So I have a similar protocol. I basically keep them in a sling for 2 weeks and then start them on pendulums, and then about week 4 get them moving, and I see them back at week 6. I see them week 1, week 2, week 4, week 6. This is the week 6 x-ray.
Dum, dum, dum.
Yeah. So now what? Resection arthroplasty.
There you go.
I don't,
Amputation.
Dean, what do you want to do now? Now it's 6 weeks. They've got limited range of motion, obviously. They've got some pain.
Now you wish you would have fixed it, that's for sure. You know, it
See, you
looks
should
like
always operate. God damn it.
it may or may not even be healed, but at this
you hope
point,
it's
I
not.
am going to operate on it. I would have operated on it much earlier, but now I'm going to operate on it. Significantly displaced. This is going to cause this guy all kind of problems. Probably going to have to do some soft tissue releases so they can get the motion back. If it's healed, I'm going to osteotomize it and fix it.
It's almost like doing an open cuff repair,
And so are you doing this open or arthroscopically?
I would do it open.
Open. Anyone trying to do this arthroscopically?
Open.
This is out of my league. This went to one of my shoulder guys, so, and I'm not sure what happened with her, so. All right, can we go back to home? All right. Bottom. All right. All right, go ahead and click on the last one all right, so I don't have his injury film. I'll start by saying that, but here's the story. 32-year-old, no medical problems. He's a bodybuilder. He works out a lot. His arms and body are covered in acne when you see him. There may be some, but there's some anabolic steroid use. It's not Jack. And so he's got some possible anabolic steroid use, although it's unclear. No prior antecedent arm pain of any sort. He was doing bench and he felt his arm snap. It's a proximal third transverse displaced humeral shaft fracture, or proximal third humerus fracture. It's transverse, slightly oblique, but nothing that looks pathologic of any sort. Initial management, I'm sorry I don't have plain films yet. I got them after the initial management, which you'll get to see plain films in a second.
How displaced? Angulated displaced.
It's not angulated. It is displaced about 100%, and it's transverse proximal third in a young, healthy, active. He's like a IT guy or a finance guy or something like that for Morgan Stanley or something.
Well, I think in my hands, you have a discussion. You have the option of treating it with bracing or surgically, and I think you have that discussion with the patient.
Yeah. This guy's a type A personality to the nth degree. He wants to get back to like working out, bodybuilding, all that stuff. He doesn't want to slow down at all.
The first thing is this doesn't make sense. Why did this thing fracture with him just bench pressing? The first thing I want to work up here before I
why.
do anything else is figure out why.
Okay. So he shows up to my office.
Yeah, yeah.
So I'm sorry, this is his immediate post-op. Any comments about surgical treatment strategy, reduction? Nothing out of the ordinary surgically.
Was there any biopsies taken at the time of surgery?
No biopsies were taken at the time of surgery.
yeah.
Yeah,
Okay, low strap, but it's a humerus, it's not a tibia. It should heal, right? Okay.
well, the biggest problem with IM nailing, I think, is the canal issue, is that you measure it and your guide wire is in nicely where the canal gets kind of narrow, and then you put your rod down, and now you don't want it sticking out into your cuff, so you wind up tapping it down a little bit, and I do see failures of IM nails for the number one reason is distraction, so.
Right.
I personally would have plated this instead
Yes.
of choosing the rod.
Okay.
Yeah, I would have
I would've
plated
plated it.
Absolutely.
Plate.
Transverse proximal third humerus, who's nailing it? Raise your hand nice and high. Couple? Who's plating it? Okay. All right. So when you look really carefully at the immediate post-op x-rays, I don't know if you all see it in the back, but you can see where the nail was and where it sort of rested. You can see the you can see that this is where the nail's seated, but when they seated it, just like you predicted, there's a fracture line that goes all the way down, and you can
Just kinda
follow
tap
it
it
really
down, that's it,
carefully,
yeah.
follow it all the way up. So this nail is essentially loose. Yeah, I would disagree with that at this point. Now, here's the deal. I didn't see him, I only got to look at these when I got to see him several months later, so I don't know if I would have picked that up if I wasn't looking for it intently. And no radiologist picked that up either, by the way. Okay, so now what? This guy comes, let's say you pick this up early. What do you do with it? Nothing. You gonna let it ride?
Let it ride.
Michael, you gonna let it ride?
I'd probably get a CT scan of the elbow and see what that fracture line
Yeah.
is like. And then if it's just a simple split, I might just put a screw across it just to hold it while while the rest of it heals.
So you take him back to the OR, because
Yeah.
this didn't get picked up in trop. Okay,
Yeah.
so take him back, maybe throw a screw. It doesn't go down into the joint. The joint's preserved or saved. Okay. So he shows up to my office May of 2017, looking like this. Anything stand out or is concerning?
What's going on distally
Oh, I'm
about
sorry.
that screw?
He hasn't shown up to me yet. He's still getting worked up. Someone wanted a workup earlier. His infection markers are negative. His tumor markers are all negative.
Got some ballooning distally
Yeah.
to the nail.
Yep.
Some
Yeah,
It's in
cortical
progression,
erosion.
yeah.
Something going on down here.
Yeah.
The fracture itself looks really good, but there's something going on down here. And I don't know if you see these little sort of lytic lesions in the
There's a lytic
humerus.
lesion at the tip, isn't there?
There's a lytic lesion down here at the tip
Yeah.
where the fracture was. There's also these lytic lesions kind of in the shaft distally as well.
Yep.
Thoughts?
I think it's infected.
Or it was pathological to begin with.
Or is pathologic? Any other?
Right.
So he gets an MRI, kind of lights up, still unclear exactly what's happening. He gets a CT-guided biopsy, which is also negative for infection and pathology. And he shows up to my office now, like that. He's got these lytic lesions.
Where was the biopsy? I'm sorry, it was at the fracture site or?
They took multiple biopsies of whatever lit up on the MRI, which was
Okay.
up top where those lytic lesions are, as well as at the level of the fracture. They also biopsied his healing fracture site and said it was healing bone. Thanks. Okay, so now it's been 3.5 months, 4 months. His arm hurts by his elbow. He's got gross motion down by his elbow joint. Proximally, he doesn't hurt at all. The arm is a bit swollen, as you can imagine. He's got limited range of motion. No draining wounds. ESR, CRP are negative, and the remainder of his metabolic workup is negative. Vitamin D, calcium, magnesium, phosphorus, alk-phos, testosterone, everything is normal.
I think I would bring him in, take the nail out, biopsy it, maybe ream, take the ream, send them off, keep him in the hospital until it's hopefully all negative. And if it is all negative, then at that point I'd probably go back and try to fix the distal part.
All right, so let's say, so decision tree number one is you're going to take him to the OR, you're going to take his hardware out. If his cultures come back positive, what are you doing for him?
You still need to fix this. I probably would fix it. I would clean it, fix it, plate it distally, and probably put a block of cement, antibiotic cement in there, and then kind of almost treat it like a joint infection. Come back and see that, put them on 6 weeks antibiotics, probably go back in later on almost as a second stage mescaline, and then biopsy it. And if it's clean, I'd go ahead and graft that area because it's probably going to need to be grafted.
Okay. And if it's clean, you're going to do that all acutely, fix it acutely.
Well, if the biopsies are clean, yeah.
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 Anybody else?
Or at least wait. I would probably wait till you get to around 4 or 5 weeks just to take advantage of the mescaline membrane.
Okay. So this is him in July. We take him to the OR. I take everything out. I ream him up. I put behind an antibiotic nail. Now, I know I don't get great purchase distally because it's a small segment, but that whole canal to me is concerning and contaminated, so I want to leave something behind. We debride what we can. I don't want to take away too much bone. It's viable, it's healthy, it's bleeding, but it doesn't look normal. It's somewhat friable. We take cultures and biopsy specimens, multiple ones, and I'm worried about something really bad, even though nothing comes up bad. Cultures grow P. acnes. Or now I think the name's changed now. I apologize. It's like C something now, right? Yeah. So he's got P. acnes. C something, I don't know. Right? And he's getting treated for that. He's got vancomycin he's got vancomycin, tobramycin, and I've started putting antifungals in my cement because we're seeing weird stuff growing out in these patients now. So there's
what do you-
antifungal in
what do you
that as
put in?
well.
What do you use?
Amphotericin. The ID folks hate it because they think we're overusing it, but it's not uncommon to see positive fungal cultures now. So he grows P. acnes from his cultures. Now what?
I mean, again, you need to, before you proceed, you're going to need to know that you have a, a clean bed. Once I finished what I think is appropriate IV antibiotics, I'd go back in, biopsy it again, and again, antibiotic cement and figure out what's going on.
So we do that. We take the antibiotic nail out, we debride him, we biopsy him again. His now cultures come back negative, but you can see the bony change that's occurred over time.
How long did you leave the nail in?
6 weeks. Elution characteristics change after about 4 weeks. After 4 weeks, the antibiotic cement doesn't do much.
Right.
So what now? I mean, this looks like, frankly, looks like garbage. This was a proximal humerus, if you remember, right?
Yeah.
So now what? His cultures are negative, but he's got this process happening, and you're watching his bone just erode.
I think you might need to do some bone transport on that. I don't think that just the bone is going to heal at all. It's aggressive. You might have to take that bone out and then transport it from proximal to distal.
All right, so who wants to resect his arm and shorten it and plate it? Anybody? Resect the bone, that's sort of that dead bone, cement spacer, and a plate.
That's probably what I would opt for.
Any other ideas?
Is that your first stage of it? Because you could vascularize fibula this as your reconstruction.
That's sort of, yeah, so I'll,
Yep. Yep.
All that out. All
Well,
that
you-
out,
I mean,
fill it
you-
with cement, plate the whole thing, come back and just bone graft it.
Yeah.
especially at
Yeah,
32-year-old.
you can't shorten that, and I don't think it's too much to just graft. So I think it's either a vascularized fibula or a bone transport, which is miserable in the humerus.
Well, but now there's not enough segment distally, but now there are bone transport nails. So you can do an intramedullary device, and we have bone transport nails that you can transport a segment of bone all internally with a magnet. And so if there were more distal bone, if this was this patient now, I'm doing a bone transport. So get another MRI, because I have no idea what to do. So just get an MRI. Just get some imaging studies, right? Who wanted the imaging studies earlier? Just get more imaging studies. Maybe something will come up. Some kind of, everyone's calling this a multifocal osteomyelitis. That's what everyone keeps referring to it as, but everything keeps coming back negative. So the ID docs say, let it ride its course. Let it ride its course, don't do anything. He's now off antibiotics. He is just hanging out. And they're waiting for the process, even those with the THC. But you can see it sort of goes up and down his canal, just sort of all over. So now it's October, everything is sort of stable. Things have not worsened. His markers are all negative. I take him to the OR and do another biopsy, and that biopsy is now negative. And so the ID docs have said everything is stable. The bone changes are sort of normalized or now what? Now back to what we talked about, big spent spacer and kind of go from there?
I guess so. I mean, I would ask ID also, is there anything that can think of that just won't grow? And is there anything that you can prepare in the lab so that it will grow? I mean, anaerobes typically don't grow. I'd just be curious, is there something?
We tend to keep our cultures now for 6 weeks.
Yeah.
And so after 6 weeks, there's still no growth. All right, so took him to the OR. I wasn't convinced that he was infection-free, so dual plated him. I used a non-vascularized fibula just to give me some stability. The bone in there was bleeding. I packed around it iliac crest bone graft, and I also put antibiotic cement on my plate. So the plate is coated with antibiotic cement, just leaving empty holes for the screws. It's iliac crest autogenous bone graft along with the fibular strut. So the fibular strut's allograft, and then around that I packed autogenous iliac crest bone graft, and then I dual plated them with the cement antibiotic plate. This is him April of 2018. And this is him December of 2018.
So there's your answer.
All right, so he is using the arm, he's working, he doesn't want to take any time off work right now. But he's looking at, and what I talked to him about was what Matt said, which is the next step for him is a vascularized free fibula. And then I have no other options after that, unless somebody else has a brilliant idea.
You ever use MFC, mediofemoral condyle?
Not here, but for other places, yeah. Scott will do an MFC for us. Dr. Levin will do MFC for us for certain areas, but not for I haven't done it for this. I have done vascularized fibulas for this, and they tend to heal. Now, the issue with vascularized fibulas for this is there has to be a way to load it so it hypertrophies, right? So that's where we'll use dynamic fixation to kind of get it to move a little bit so it heals a little.
Still bench pressing.
Can we click home? I just have other people seen this multifocal kind of chronic osteo from P. acnes? I mean, usually it seems to be much more contained than that. You guys have seen multifocal?
No.
Okay.
That's good, yeah, that's exactly, you introduced it from the shoulder.
Yeah.
Yeah, just a couple of things with that, the biopsies are notoriously negative.
Right.
P. acnes because it's the ones that are study are negative control and positive control. We put everything in the tubes immediately because if they sit on the back table in an open container, the growth rate of Cutibacteria or whatever, P. acnes, goes down. So if you do it in an open container, there's too much oxygen in your culture, sensitivity is going to go down. So you really want to put it in a closed system immediately. So I handle, when we do it, I put them all in. You got, like you did, you have to do it surgically.
Right.
You can't rely, because they probably held the cultures for 3 days.
Yep.
When they did the open or the needle biopsy.
So just a quick question on that. How do you explain that the actual fracture healed there? I mean, it's kind of strange that that would heal, but then distally you would have this bad osteolytic reaction. It's almost like the P. acnes is opportunistic. Like it finds an area that is weak and goes after it. I don't understand how that can happen.
It's a great question. I don't know why the proximal, I'd love to read what the panel thinks, why the proximal side healed and healed uneventfully. I mean, there was no disease that tracked proximally at all. It was all distal half of his humerus.
Yeah. Yeah.
Right, but why wouldn't it contaminate the entire canal? And why would the fracture proximally heal? And why wouldn't you see lytic lesions running all the way up if it's opportunistic?
It just looked like the bioburden was most
Distal.
more so than
Yeah. Another case, you can pick it.
How about run-of-the-mill old person fall?
All right, run-of-the-mill old person fall.
This is like every one of mine.
Can you click on that link?
Fractures.
All right, 82-year-old right-hand dominant priest, ground level fall. No, not a priest with a girlfriend, ground level fall. Those are different initials. Jesus Christ. All right. Michael, what do you want to do with this? What's your gut tell you right now?
So I'm going to treat this non-operatively. I'm going to put him in a sling for 2 weeks, have him come back, repeat x-rays. You know, if it doesn't look, you know, as long as the shaft is still under the head, I'm going to continue to treat it non-op. I get him out of the sling at 2 weeks, start pendulums, elbow, wrist, and hand, and then at 6 weeks I start, shoulder and overhead exercises.
Carrie?
Same thing.
Non-op?
These do really well usually in the older patient.
Okay. Anybody fixing this on the panel?
Nope.
Does that change your decision-making at all?
Nope. No.
It reverses your good bailout.
Anything else you want to know about this patient? Intra-op pictures? Like the first case that we said that we might or might not operate on, this one popped up really well. Big void behind. What do people routinely fill? Are you filling that defect and what are you filling it with?
Allograft.
Yeah.
Allograft?
If the iliac crest allograft is really nice because you can cut it into a triangle, high side lateral, and it really holds the head up nicely.
Anybody using, are people still using allograft struts at all or no? Little fibular struts in here?
You
are
use it,
still?
yeah.
Occasionally, not
Okay.
often, but occasionally.
Are people in the audience still using fibular struts for these? Sort of?
Yeah.
Jerry, comment about it or just using it?
I don't do a lot of them because I get to try to go through them when they're in there.
Right.
And I need a reverse, so I try not to use them a lot, but this is one of the situations where I would.
I think if I was going to operate on this person, though, I would never try to fix it. I would just go to a reverse.
Yeah.
Who said
I
reverse?
agree.
Reverse. Oh, everyone here is
Yeah.
doing reverse.
If we
Wow.
were- yeah,
If we
gonna
were
operate
fixing it,
reverse.
yeah.
Yeah.
Audience, who's doing reverse for this?
If you can, yeah.
If it needs surgery, okay, interesting. He's 82, yeah, no,
Let's vote how many people would operate on this and who would not.
all right, who wouldn't operate on this off the bat?
Who would or would not?
Who would not operative? Okay, mixed bag, all right. So pinned him, wired him up, plate, filled the void, and actually injected cement or biologic cement into his defect. And that's him post-op. And he actually went on to heal. He's got a little bit of restriction with forward flexion, but short of that, he feels really good. Didn't fail, didn't go into AVN. So maybe I did deltoid split, yep. Essentially, the only thing I don't do deltoid split for anymore is
No, I
head
do all
splits.
delta.
Everything else is deltoid split. 3 parts, 4 parts, 2 parts. Or if there's a concern for a vascular injury. If there's a concern for a vascular injury, I go delto-pec. But short of that, it's all deltoid split.
I think sometimes what I've seen with these people is the greater tuberosity won't heal and a resorb, and they end up getting almost like the equivalent of a pseudo-paralytic shoulder because they don't have that cuff attached. And then I've had to go back and take these plates out and then do a reverse at that time for those. Which can
Who's
be challenging.
routinely, that's actually a great point. Who's routinely having to go back and take out proximal humeral locking plates due to stiffness? Anybody?
Wouldn't say routinely.
Not
but
routinely, once in a while. Routinely taking out hardware proximally from the humerus.
I'm probably doing it 30% of the time.
30%? Anybody about the same?
No.
Yeah, range of motion I feel like
Not
is
even.
better.
For pain, would you say, Greg, mostly for if they're in pain?
I don't know, it just seems to.
Yeah.
There's a,
Yeah. Other comments? That's our other guy. Click on the home button. All right. Thank you, guys.